welcome everybody. Welcome to Spinal Paradigms, Analysis, and Rhetoric. We have a very distinguished panel today. We're going to talk about the treatment of cervical radiculopathy, its full spectrum of presentation and continuum of care. Our distinguished panel today includes Dr. Roger Hartle, who's a professor of neurological surgery and director of spine surgery at Weill Cornell Medical Center in New York City. Welcome, Dr. Hartle.
Great having you. Thank you.
Next is Dr. Dom Korek, who's the chief of the Department of Neurosurgery at Carolina Medical Center in Charlotte, North Carolina. He's the spine director of the Neurosciences Institute at Carolina's Health System. Welcome, Dom.
Thanks, Paul. Thanks for having me.
Yeah. Next is Dr. Richard Geyer, who's the co-founder of the Texas Back Institute and director of the Spine Fellowship Program and co-director of the Center for Disc Replacement at the Texas Back Institute. Welcome, Dr. Geyer.
Thank you very much, Paul.
I don't think there's any question what side of the spectrum of care you're going to come down on. And also helping moderate this evening is Dr. Sig Bervin, who's a professor in residence and chief of the spine service at the University of California, San Francisco Department of Orthopedic Surgery. Welcome, Sig.
Thank you, Paul. Thanks for organizing.
Sure. And I am Dr. Paul Houle. I'm a neurosurgeon at Cape Cod Healthcare Department of Neurosurgery. I have a side gig as a commercial fisherman. So welcome everybody. Let's go ahead and jump right into the presentation. So this is a very straightforward case. It's a 38-year-old guy who came to see me with a 2-month history of right arm pain and neck pain following a work-related injury. His C6 radiculopathy consisted of pain, numbness, and weakness of his hand. And when I saw him in the office, he couldn't hold his head up straight. He couldn't find a comfortable position. He kept shifting all the time. And he did have a weak grip and diminished sensation in the right C6 distribution. We had tried to get him to do physical therapy, but this was right when COVID hit and all the physical therapy places closed. So he was doing a home, self-directed home exercise program, but his hand was getting weaker. So prior to the invitation, we sent out some questionnaires. How would you treat this? So I want you to think about how you would treat this case, and after we're done with the presentations, perhaps people who are watching will be able to write in how they would treat this patient. So Dr. Hartle, why don't you go ahead and give us your presentation?
Thank you, Paul. So my name is Roger Hartle in New York. Paul was talking about his career as a fisherman, and he was talking about the white sharks, Cape Cod, and I feel like I'm surrounded by the spine sharks tonight here. But I'm just joking, of course. But I want to talk to you, next slide. I want to talk to you about my disclosures. Next slide. So I want to talk to you why I believe that for this particular case, posterior decompression without fusion is a great solution. And if you recall the case of this patient, the films, this patient has a radicular problem. This patient didn't have any axial neck pain. And a neurological deficit clearly defined from one level. At reasonable low doses, there was no deformity. Why do I believe that a decompression from the back without any type of implant or fusion is a great solution for this particular pathology? I'll give you the 6 reasons why I think that a cervical foraminotomy / discectomy from the back is a great solution in this case. First, you're going from the back, so you avoid anterior access related morbidities. I was seeing patients today, and there's a morbidity from anterior surgery. I had one patient come in from a different institution who had a vocal cord paralysis after ACDF. So it can happen. It's a rare complication, but if it happens in somebody who's young and active, it's a terrible complication. So you avoid those types of complications. Second, Paul, if you just scroll ahead, it's an incredibly cost-effective operation. There are no implants involved. Patients go back to work very quickly, and there are studies that show that it is cost-effective and very reasonable in terms of the costs of the surgery. Next, Paul, it's motion preserving. We're going to hear later about disc arthroplasty, which is great because it preserves motion, while a posterior foraminotomy by definition will preserve motion. Next one, Paul. It's ambulatory. These patients typically go home the same day. It is true that with anterior surgery, you can send patients home sometimes the same day, but it's still not really common practice. Usually these patients stay at least one night in the hospital. With posterior foraminotomies, they frequently go home the same day. Next, Paul has a great track record, and I'll show you some data. And finally, Paul, one more, it allows future anterior approaches. So in those cases where you still have to go back, maybe at a later point to do a revision, you can still go in from the front and do an ACDF, a fusion, or disc arthroplasty, or whatever you have to do. Next slide. Now, the laminoforaminotomy has been described in the late 1940s. Frickholm here published that in 1949, as you can probably see. And then since the early 2000s, we've been increasingly, at least in North America, we've used tubular access retractors and the microscope to perform this operation. Next slide. And how do you make that decision? And I think, you know, this talk or this whole evening is really about decision making. And that's why I wanted to walk you through this algorithm that I use when I select these patients. Now, if somebody has spinal cord compression, as the patient here on the right side, that's not a good indication for posterior foraminotomy. That's actually a contraindication. But patients with radicular symptoms, like here on the left side, where you have compression laterally, where that nerve root is coming out of the foramen, in those patients, a posterior approach may be a perfect option. Next slide. So what is the option? Next slide. It depends on the clinical presentation. If somebody has a lot of neck pain, axial neck pain, I tend to prefer a fusion or a disc arthroplasty. But if it's purely radicular, like in the patient that we discussed earlier, a posterior approach with just a decompression is a great option. Next slide. So radicular symptoms, no myelopathy, no axial neck pain, option for posterior approach. Next slide. No axial neck pain, and then we look at the alignment of the spine. If a patient has normal lordosis, like the MRI scan on the left side, that is in favor of a posterior decompression without fusion. If somebody has reversal of the cervical lordosis or kyphosis, like the patient on the right, then I go from the front and I most likely will do a fusion. Next slide. So again, the indications are no axial pain, normal lordosis, and then lateral disc. If somebody has a central lateral disc with spinal cord compression, a posterior foraminotomy is obviously contraindicated. But if the patient meets these three criteria here on the left, a posterior cervical discectomy or foraminotomy is a very, very viable, cost-effective, and safe option. Next slide. Next one. And you can do it, and this is just from the operating room, an X-ray. You can do it adjacent to a previously performed ACDF or disc arthroplasty. This is a patient who had two anterior surgeries done before. Rather than going back from the front and doing another fusion or disc arthroplasty, we decided to do a posterior foraminotomy in this patient. And you can do this safely, even above multi-level fusion cases, as long as you are careful not to remove too much bone, of course. Next slide. Posterior foraminotomy, again, you can do this for bony compression as indicated or shown on this CT scan. This patient has severe left-sided foraminal bony compression, or you can do it for a soft disc herniation as in the patient that we had introduced in the beginning. Next slide. I'll just scroll through it. The main, next slide. The main disadvantage here is really that there's no reimbursement for this type of surgery. It's not as favorable as it is for any type of surgery where you use implants, unfortunately. Next slide. And how do we do this in the operating room? There are many different ways of doing the surgery. For a while, I used to do it the way that it is described here with Gardner-Well tongs and traction. And I would make a small incision, place a tubular retractor under fluoroscopy guidance. Currently, I use a Mayfield head holder because I will frequently use navigation for localization in these patients. Next slide. I always use a Jackson table, a small tubular retractor. I use a 14 or 15 millimeter tubular retractor for a cervical foraminotomy. On the right side, you see a post-operative CT scan that shows the defect. Obviously, you have to be careful not to remove too much bone. You want to leave at least 50% of the lateral mass and the facet joint. Next slide. Localization, I typically use fluoroscopy. In the lower cervical spine, that can be a challenge. Next picture. Sometimes you can use AP fluoroscopy for localization, or next picture. For many cases now, I use navigation. We have 3 or 4 navigation systems available in the operating room, and it just makes it so much more streamlined. If you use navigation, you can use it for localization of the pathology, the tubular retractor, and then also to make sure you don't remove too much of the facet joint. Next slide. And then we bring in bayoneted instruments under the microscope. Next slide. And the landmarks are the V-shaped gap between the lamina above and below. You want to see the junction of the facet joint here. Next slide. And then you remove a little bit of bone above and below with micro instruments to expose the pedicle above and below. Next slide. Once you see next slide. Once you find the pedicle, you know that the exiting nerve root is going to be between those pedicles. You identify the nerve root, find the disc herniation, and remove the disc herniation microsurgically. Next slide. Next slide. Now the anatomy is, you got to be careful because there are sometimes 2 nerve roots there, the motor branch and the sensory branch. You got to make sure that you identify both. Sometimes if you're not careful, you can think that the sensory nerve root is the disc herniation, and that is obviously not good. So you got to be aware of this, of that intraoperative finding. Next slide. That's an intraoperative image of the exiting nerve root here in the thecal sac and the disc herniation, typically caudal to the exiting nerve root. Next slide. Next slide. This is the cape. Yeah, this next. And then studies, I'm going to go through a few studies. If you go to the next slide, this study showed, it was a cost-effectiveness study comparing ACDF surgery to cervical foraminotomy and showing that it is very cost-effective because the direct costs are less, there's no implant, and patients tend to go back to work earlier. In that particular series that was done in the military with cervical foraminotomy. This is a study that was published recently in 2018, a meta-analysis comparing clinical outcomes from different types of surgeries, ACDF versus cervical disc replacement versus posterior cervical foraminotomy. And this particular study found that clinical outcomes were very similar, but there was a difference, a significant difference in terms of secondary surgical procedures. Next picture, if you just click down. So the authors here looked at almost 360 studies, and they found that the rate of secondary procedures was much greater after ACDF surgery, and the incidence of adverse effects was the lowest in patients who underwent a posterior cervical foraminotomy. So it was the safest operation and a very low rate of secondary procedures. Now, the next 2 studies I want to show you try to look at long-term or longer-term outcome. One of the biggest concerns with posterior cervical foraminotomy is the longevity of the success of the operation. Critics say that, you decompress the nerve root, but then down the line, patients develop a deformity and may need more surgery to have that fixed. At 2 years, however, and this is a study that was published recently, if you click through this, and shows the text, 790 patients. They matched patients who had ACDF surgery versus posterior cervical foraminotomy done, and there was no difference in 2-year reoperation rates in these patients. Next slide. This is a study that was just published a few months ago, a 5-year outcome study from a Swedish patient registry where they have a really good handle on following these patients long-term. Clinical outcomes here, ACDF versus posterior cervical foraminotomy was the same. There was a slightly higher rate of reoperation, however, in the cervical foraminotomy group, but it was not significant. If you click through this, so adjacent segments, there was no difference. Next slide. And another reason why I like the posterior approach, because you can also do a direct decompression of the spinal canal. This is an older patient who we operated on. We did a foraminotomy and we did a decompression of the spinal stenosis at the same time. It's something you cannot do if you go in from the front. Next slide. And next slide. And that concludes my presentation. Again, I feel pretty strongly, or very strongly, that for the right patient, this is an amazing operation.
It's cost effective. Patients go home the same day. It's very safe. It's got a great track record, and it saves patients an implant. So thank you so much.
So, Dr. Hartle, one of the hurdles that I hear from people who are doctors who want to do posterior cervical is that they feel that, especially in the prone position, there's an awful lot of bleeding, and it's oftentimes difficult to control. And I know in Dr. Korik's group, that's done in the sitting position, and I think nowadays the sitting position is kind of a lost art. So how do you feel about that?
Yeah, I think that's a very good point. I use a Jackson table in reverse Trendelenburg, and the higher you elevate the head, the less bleeding. You have to use sometimes standees to use on a standard, so you can really get the height up of the head, but that is a concern. But if you elevate the head with reverse Trendelenburg, you get a really nice handle on that.
Excellent. Dom, do you have anything to add?
Yeah, I will touch base upon that. I think the sitting cervical, there's a lot of advantage to, and I think Roger hit some salient points. I'm just going to have to apologize to my esteemed colleagues Roger and Rick about the beatdown I'm going to have to deliver a particular patient.
I know, I saw your slides, so you guys just wait till it's coming. But one last question, Dr. Hartle, because I know that you are involved in spinal endoscopy, and wonder what role do you see in the future for spinal endoscopy for cervical foraminotomy?
Yeah, I think it's definitely a good option, and there's still research being done. I think we don't really know if it's really significantly better than tubular decompression, but it is an option. There are some surgeons, especially in Asia, and a few surgeons in North America who are really good with that. And we've got to look at the outcome data. But essentially, it's the same. It's a very similar procedure to the tubular through a smaller incision. What is not a good option is endoscopic percutaneous without visualization. That has been discussed also. That I think is dangerous. But as long as you have direct visualization, it's probably very similar to the tubular decompression.
Excellent. So we'll just.
Roger, tell us in terms of imaging, Roger, what do you use for imaging to try and determine if you've got a patient with a significant foraminal disc? What do you use for imaging to determine whether or not that disc may be something that you can actually fish out versus if it might be more of a calcified unstable complex or
I will frequently get a CT scan, and that can be very helpful because it helps you determine what to expect once you're in there. If you expect a soft disc herniation, you will look for that. And if you know based on the CT scan that it's really calcified, you're not going to do unnecessary manipulations of the nerve root looking for a soft disc herniation, and you will essentially unroot the nerve root. So that's a very good point, and that's a very important point.
So,
Roger, if you've got a patient who's truly got weakness, do you favor an anterior approach, or do you think you can do as reliable a job on a patient with weakness with a foraminotomy?
Oh, absolutely. I have no doubt you can, especially if it's a soft disc herniation, you can completely treat that from the back, and very, very successfully. I'm just not sure if there are two sick Bervens, or is that just an old picture?
I'm afraid I've got a little bit of an unstable internet connection here.
There you go. So I'll just take a little plug. I know, Dr. Harley, you've been hosting a MIS course for quite a long time. Unfortunately, I've never had a chance to attend, but you have another one coming up in December?
Yeah, it's going to be virtual this year, and you're always invited, of course. And yeah, it's going to. We try to focus on navigation, endoscopy, and virtual reality, all the fancy new technologies.
Wonderful.
Thanks for pointing that out.
Oh, thank you very much. Now we're going to move on to Dr. Korik.
Appreciate it, and thanks for having me. And Roger, thanks for the great presentation. We can go to the next slide. So this is my disclosure. This is our crew in Charlotte, kind of always an outdated photo because we always have new guys coming in. We're up to about 40 neurosurgeons in Charlotte and Greensboro area. And so we're always trying to stay on the cutting edge. And let's go to the next slide. So again, briefly to go back over the case, there was neck pain as presented. There was some component of neck pain. And if we look at the MRI, it does show that there is a fairly large size foraminal disc herniation. Like Roger was talking about, sometimes you can get a CT scan to tell the bony anatomy. You don't need that here. You get a pretty good shot at the facets, which look pretty good, and you got a good size soft disc herniation. So let's go to the next slide. And then the full picture you had showed previously, Paul. And again, I want to thank you for picking the perfect patient for ACDF because this is a workman's comp case. There is axial neck pain in addition to the radiculopathy. And Roger talked about the loss of the normal curvature, but there was clearly a loss of lordosis, as well as focal more than focal spondylosis. The moderate spondylosis, at least moderate 5-6, and at the other levels that you showed previously, there was kind of mild to moderate multi-level disease. And I'm not sure if this has been mentioned or not, but this is a workman's compensation case. So let's go to the next slide.
Now, don't hold back. Tell us how you really feel.
Yeah.
Is it workman's comp?
My friends rarely accuse me of being an internalizer, so I'll try to just throw it right on out there. So if we go to the next slide. All right. Not seeing it. I'm seeing the kind of telephone screen, 6 telephone screen there.
It's your ideal indications.
So if we look at the ideal indications, these are all different procedures, and these are all procedures that we do, that I do personally, and I think that there are really 3 great procedures, but they all have their different ideal indications. ACDF is better for moderate to severe spondylosis, better for multi-level disease, better for patients that have a loss of lordosis, and certainly better for facet disease. And then cervical arthroplasty, which Rick will talk about. Dr. Geyer certainly has a huge experience with this, and I think a lot of the literature he'll quote, I was involved with some of that with him as well. But this is a relatively limited indication list in terms of exactly what the indications are from an ideal perspective. And if we look at cervical foramintomy, it's even more limited. Like Roger said, it's really for only unilateral pathology, 1-level disease, and you really need to have a clean radiculopathy with little or no axial neck pain. And so as we go down from ACDF, we see the kind of workhorse procedure, and we see some more limitations with cervical arthroplasty, and we see the most amount of limitations for posterior cervical foramintomy. Let's go to the next slide, please. So if we talk about the actual the case that's been presented here, and Roger's already spoken about cervical foramintomy, it is what are the downsides of it? Well, it is not ideal for a primary component of axial neck pain, and it's technically challenging to safely resect a large foraminal soft disc from a posterior approach. Roger touched upon it. Unfortunately, most of us aren't master technicians like Roger, and it is difficult to drill down the pedicle. And we do it sitting cervical. Roger talked about doing it prone, but you're getting blood welling up in the wound, drilling down the pedicle. You're trying to identify the sensory root from the motor root. You're getting into the axilla, poking around with the nerve hook, and you're trying to get that hunk of crab meat out of there. And the reality is that this is a technically challenging procedure at the best of hands. As far as cervical radiculopathy, as cervical radiculopathy being treated with arthroplasty, again, this is not a definitive procedure. This is a workman's comp case, and with cervical arthroplasty, there's always something you can do beyond your arthroplasty. In other words, even if you have a perfect looking X-ray and the patient isn't doing well, you can say, well, I want to do the definitive procedure. So you're looking to do a next procedure after doing the kind of a middle procedure. It does not do well with patients with loss of lordosis and even moderate spondylosis. This is a procedure that is ideally treated for early to moderate degenerative disc disease. This patient's probably a little bit more advanced than that. And then if we look at the negatives for ACDF, my friend Dr. Geyer is going to talk about the loss of motion and about the adjacent level disease that you can see with ACDF. So let's talk about some of those issues. Let's go to the next slide. And so if we look at the probe for posterior cervical laminoforamintomy, Dr. Hartle is exactly right. It is a minimally invasive procedure and it is a motion-preserving procedure. We find it ideal for highly motivated individuals like athletes and professionals. Our experience, and most notably Tim Adamson, who's one of the pioneers, if not the pioneer in this field, we've had excellent results with NASCAR and NFL athletes, highly motivated athletes. I don't know what kind of patients Ryan's treating in New York, but it's not been my experience that workman's comp and litigation patients are quite as highly motivated as professionals to get back to their exact level of activity prior. This is one of my actual cases where we do it, like Paul said, sitting cervical with the laminoforamintomy with the tube. Go to the next slide. So let's talk about some of the negatives for posterior laminoforamintomy. It does not address and really may potentially accelerate the underlying degenerative process. And additionally, like I've previously been discussed, it's technically demanding in the best of hands. And like I said, we all can't be Roger. And this is quickly becoming a lost art. It's not something that you see residents familiar with, and drilling down the pedicle and working around that nerve root, especially when you have a large foraminal fragment like we talked about. It generally involves manipulation of the root and kind of can predispose towards neuropraxic injury and some of the things that led to the adaptation of anterior approach to begin with. Again, this is our setup for posterior cervical laminoforamintomy, which we do sitting cervical, and one of our patients. So let's turn both barrels to Dr. Geyer, and so let's get to the cervical arthroplasty. Next slide. So ideal indications include radiculopathy secondary to soft disc disease, and if you kind of look at this slide, you can see how all the discs look the exact same. There's not a real focal spondylosis, and it's a soft disc herniation. So this is kind of the ideal indication. Let's go to the next slide. Some of the contraindications to cervical arthroplasty are directly related to the complications you can see. When you're dealing with patients with advanced spondylosis, predisposed towards heterotopic ossification. If you're dealing with patients with osteoporosis, you can see subsidence. And if you're dealing with patients with multi-level disease or global kyphosis, you can run into other problems. So let's go to the next slide. Let's see some of the complications we can see. And this is what I mean when I'm talking about we're not necessarily doing a definitive procedure. These are some of the problems that you can have. And let's go into some of these individual cases. And so these are all cases, luckily, they aren't all necessarily my arthroplasty cases, but they're all cases that I've seen in my clinic. And this is a patient who came in with a displaced inferior artificial disc. And you see the final common pathway is ACDF. Next slide. You see an expulsion patient, again, with the entire arthroplasty expulsed into the prevertebral space. Next slide. You can see osteolysis, which is an eroding away of the end plates. And typically the answer to this procedure is, answer to this complication is an anterior cervical discectomy infusion. Next slide. Then we see heterotopic ossification. And this is actually one of my patients. And you can see over the years how the patient became a little kyphotic to begin with and ultimately developed a solid fusion over a period of several years. And that is something that you can see with every arthroplastic device, no matter what your technique is. We see it across the board. And it is a potential complication, although not clinically relevant. It really doesn't do any better than having than a fusion to begin with. Next slide. And then here's an interesting case, because let's look at that MRI, and it doesn't have quite as prominent a foraminal disc herniation, but there's some foraminal stenosis. And this patient is a 38-year-old. And if you look at the spondylosis and the lack of lordosis, This is a hauntingly similar case to the one that's been presented by Dr. Kuehl, and it is actually a C6 radiculopathy as well. There's some axial neck pain, and there's loss of that normal lordosis with a little bit of focal spondylosis. Is any of this sounding familiar, Dr. Geyer? So
not at all.
Slide. Look at the intraoperative pictures. They look perfect intraoperatively. Look at that artificial disc. And then let's go to the next slide. And then what we see here is a little bit of preload of the artificial disc. The disc is thrown into kyphosis. And then look at the CT scan with the disc in kyphosis. This is a workman's comp litigation patient. The patient's radiculopathy is completely resolved, but they have axial neck pain. They have a picture that looks like this. So what are you going to have to do? Next slide, please. You're going to have to revise it to the more definitive procedure, which is an ACDF, despite the fact that the patient's radicular symptoms are completely resolved. Because your x-rays don't look perfect, there is something else that you can do. Let's go to the next slide. So let's talk about some of the pros of arthroplasty. And so it utilizes that same familiar anterior approach. It also is minimally invasive and motion preserving. But what is the negative of it? It is certainly a more novel procedure and it's more technically challenging. The vast majority of spine surgeons are already expert ACDF technicians. And so, and then first and foremost, especially in a workman's comp case, it's just not a definitive procedure. And so if something goes wrong or if the x-rays don't look perfect, there is something else you can do, and that something else is ACDF. So let's go to the next slide. So for this particular workman's comp patient with a paracentral foraminal disc with neck pain, moderate spondylosis, loss of lordosis, the most definitive procedure, ACDF, is the procedure of choice. It's not called the gold standard for nothing.
And I'm going to do a sound effect. This is you dropping the mic.
All right, we got a little more. We got a little more if you guys can take it. So let's go to the next slide. So we see what are the advantages. It's a definitive workhorse procedure. It is virtually every spine surgeon is an expert technician in this particular procedure. It also is minimally invasive. We've done several thousands of these outpatient, 1, 2, and even 3 levels with excellent results. And what are the cons? Again, the loss of motion, the adjacent level reoperation. So let's talk about that a little bit, shall we, Rick? Next slide.
Are you going to give my entire talk?
So if we look at adjacent level disease, let's look at the Hillebrand seminal article from 1999. And in that article, he describes adjacent level symptomatic disease, which is a combination of reoperation and the presence of this non-validated criteria of on 2 consecutive office visits to have adjacent level symptoms referable to one of the levels above and below. So this is a totally vague and non-validated criteria. Let's go to the next slide. If you look at that paper and you look at Allen's numbers, you'll see that the actual adjacent level reoperation rate, which is the actual thing that we care about, is incredibly small. It actually has an annual rate of 0.66% per year. So annual rate of reoperation less than 1%, really 0.7%. So the rate of actual reoperation following ACDF, incredibly small, and not the 3% that we quote reflexively from Hillebrand's article, because he includes this non-validated criteria. So let's go to the next slide. So if we really look at adjacent level reoperation, it's a multifactorial etiology. There's so many different things that go into it. So at the end of the day, the choice of actual arthroplasty versus ACDF versus foraminotomy is just one of those factors. And you can certainly have adjacent level disease with all the procedures that we discussed today. Go to the next slide. So let's get back to the loss of motion. Rick's going to talk about this, but approximately 50% of the cervical spine motion occurs from the occiput to C2. The remaining 50% is split amongst the other levels. So let's do some math that even my buddies in orthopedic spine surgery could probably do. That's
Boom.
6 divided by 50 is about 8% per level. And at 8% per level, it is difficult to argue that the loss of motion at a single level is going to result in any kind of clinically meaningful limitation of range of motion. And so this is not the C2 to T2 that we're seeing here. Again, this is another one of my cases, but this guy has the loss of motion
you'll take that loss of motion, but when you have one level ACDF, you're just not going to get a clinically significant loss of motion. Let's go to the next slide. So Roger touched upon this a little bit. So this is a workman's comp case, and let's look at the RVUs that are associated with each of these procedures. So we get about 75 for ACDF, 45 for cervical arthroplasty, and 35 for posterior cervical foraminotomy. So we're getting paid significantly less to do more technically demanding procedures, which are actually less definitive. Makes sense, right, Roger and Rick? Sounds right to me. Let's go to the next slide. So this is a slide that talks about our experience at the surgery center. So he's saying it's all about the money. Well, if you do this in the surgery center, like we've been doing for the past 10 years, per ACDF, you save anywhere from about 30 to 40% from your hospital charge. And these charts are from a published paper that Matt McGurk did for us, where we looked at the outcomes, inpatient and outpatient. The clinical outcomes are exactly the same, and yet you're saving 30 to 40%, which translates into about 7,000, 8,000, 9,000 per case, way in excess of a couple of extra RVUs that the surgeons deservedly getting. So let's go to the next.
Well, wait a second. So why do you think that inpatient ACDFs take longer to go back to work than outpatient ACDFs? You're doing the same operation.
They don't. They didn't. It is an expectation kind of thing. As we know, we all set our expectations. When we started doing these 14 years ago, everyone was like, my God, how can you do ACDFs as an outpatient? Now it's become commonplace because the expectation is set. For instance, when I do my outpatient ACDFs, I don't use the collar. I don't tell the patient they can't do anything for a month. I tell them, just like with my arthroplasty patients, start moving your head right away, no collar. You're not going to be out of work for a month. You're going to be, I want you driving after about a week or two as soon as you get off of muscle relaxers and narcotics. And I want you back to work in the same, I tell them the same things I tell my foraminotomy patients and my arthroplastic patients, which are, mobilize early and often and get back to work sooner. And there's a self-fulfilling prophecy. If you slap someone in a collar for 2 months and you tell them they can't move their neck, they're going to get to work a lot later than if you do a foraminotomy or an arthroplasty and you tell them they could do things right away. So in conclusion, spine surgeons really do have 3 efficacious and minimally invasive procedures to treat cervical radiculopathy. And again, in deference to my esteemed colleagues, all 3 really have an excellent firm evidence basis for usage. But it's at best a moot point and at worst counterproductive to attempt to debate which procedure is theoretically superior. They're all great procedures. The focus needs to be on maintaining competency on all 3 and matching the individual patient to the proper technique. So next slide. So to minimize failed surgery, it comes down to patient selection, patient selection, patient selection. And for this particular patient, ACDF is the most definitive and best procedure. This interesting patient at the bottom here is also one of my patients who actually has undergone all 3 of the stated procedures all in one patient. He has a cervical arthroplasty, he has a cervical foraminotomy at the middle level and the lower level, and he has ACDF at the lower level. So this patient actually has all 3, proving that they're all good operations. The patient is an actual tennis coach who's still playing tennis at age 60 plus. Next slide. That's it, fellas. I appreciate your attention and thanks for having me.
Well, thank you very much. I think that your point that we should master all 3 techniques and utilize them and have each of those arrows in our quiver, I think is a very, very, very good point. So, what do you how do you think Cam Newton's going to do up in New England this year?
You can have him. We're not going to miss him.
So, I do have a question. If nobody else has any questions for Dom. So, if you're doing a cervical arthroplasty, do you treat that person differently in terms of return to work, single level ACDF and single level arthroplasty?
No. No collar. Get back to. Don't drive or take it easy for about a week or 2 at the most, and then get back as soon as you can. And typically, I feel like my return to work numbers personally are very similar for arthroplasty and ACDF. And it's interesting because, all kidding aside, Rick and I have collaborated on numerous things.
The last two studies, arthroplasty studies that we've been co-investigators for the country, have been the M6 study and the Simplify study, two really modern generation discs. And every one of the patients that we enrolled in those studies were done outpatient. And like I said, we routinely do 1 and 2, 3 level ACDFs outpatient, same situation. And virtually all our cervical foraminotomies are outpatient.
Excellent. Okay, Dr. Geyer, let's turn it over to you.
All right. Hope I can see my slides. Well, listen, to follow Roger and to Dom, it's really a hard play, but I promise you, I'm not going to talk about foraminotomy, and I'm not going to talk much about fusions. Next slide. And sorry, I don't have my disclosures, but I do consult for a number of cervical arthroplasty companies. So the question is, what's the best option for this patient? Next slide. And as Dom ended up, there really isn't a bad option. And unfortunately, the decision is oftentimes made on the biases of the surgeon's experience of the various techniques, although I do agree that you should be facile in all three. But in most areas of spine, there's more than one acceptable treatment option, and rarely is it black and white. And until we have more data, registries, and predictive analytics, our decision-making will be primarily based on the first point. That is based on your experience and your biases. But I am here to talk about cervical arthroplasty. So I am going to try to defend why this is a great choice, whether it's workman's comp or not. So next slide. So coming from the orthopedic background, in 2020, there's been a trend towards preservation of motion and MIS techniques. So for example, if Dom or Roger had a bad hip and you went to see the hip surgeon and he offered you a fusion, would you accept that? Would you say, isn't there something better? Next click. So obviously nobody today undergoes a hip fusion or a knee fusion, even in the face of infection. Next slide. So the same holds true for the neck. When we have the options of doing motion preservation, and yes, foraminotomy does the same, why would we offer the patient a fusion, even though Dom has very well showed that most of the motion comes from the upper level and maybe it doesn't cause any problems. Next slide. So as Dom said, cervical arthroplasty has long been considered to be the gold standard, but there's been no area in spine, and I mean no area in spine and all of orthopedics, and I'd venture to say even in neurosurgery, although I'm not as knowledgeable about your literature, there's been no area where there's been multiple RCTs and has been consistently found that TDR results are similar or superior to ACDF. Next. So it's widely creeping up. Somebody needs to mute their microphone. But anyway, so here's the Hildebrand article. And but the real problem with ACDFs are that you have problem with plates, you have problem with pseudoarthroses, you have problem with subsidence of the graft, and with migration of the screws into the next level. Next. So we have 8 completed FDA trials thus far, and all the data is available in the public domain. All of them are prospective randomized level 1 trials comparing TDR to ACDF, all with 1 level and 2 discs having 2 level data. Next. There's many different artificial discs. One of the nice artificial discs that Dom showed in one of his cases that went on to an autofusion is the Bryan disc. But you see listed here, these are the 8 approved discs. The ones in red have been taken off the market because now we have more modern discs. And the most recent one was the viscoelastic disc, which is the M6, which not all artificial discs are the same. The M6 disc actually has a center axis of rotation and lateral bending and flexion extension, very similar to the normal spine, whereas the others are basically ball and socket or sliding. Next. We also see that there's a number of other studies that have been done. Dom and I were co-PI on the Simplify 1 and 2 level, and we're hoping to get approval or see approval at the end of 2020 and early Q1 for the 2 level. Sentinel's also doing a study on their European available disc that we don't have here, the Synergy disc that is coming from Canada, the Diamondcron, which is made out of a unique diamond material with unique surfaces, and the Spine Art Bagara C. These are future studies. Next. And then we have a number of studies that didn't come off. Dom and I were co-PIs on the Kineflex, which is a metal, which unfortunately went by the wayside, like all metal model implants, even in the hips and knees. And then we see another several artificial discs that didn't make it, and many of them we saw before that showed failures. Next. Currently, these are available outside the U.S. There's a couple viscoelastic discs. One is the Freedom disc, and the other is the Rhine. Next. But if you look at the number of publications, and in the, and I don't know if it shows up real well, but in the red outline bars we see in 2017, there are a huge number of discs now published on cervical arthroplasty. Next. And all the single level trials found the TDR to be non-inferior to ACDF and superior in some measures. And the results have been maintained up to 10 years with long-term follow-up now available in 3 of the studies. Next. And if we look at the NDI scores, and granted this has TDR and ACDF, but remember these studies were compared, and we see out to 10 years, and we have, and it's kind of small for us to read, but the 3 lines out to 10 years are the artificial disc, and we see that the improvement of the NDI is maintained out to 10 years. Next. And what this shows is that the data is very, very reproducible across multiple devices in all these multi-center trials. Next. And also we have data from multiple other countries that show the results the results are never less favorable compared to the ACDF. Next. We also see in this study that with 330 some cases follow up at 5 years, that there's only 4.5% revision in the arthroplasties. Next. And in this meta-analysis, they showed that TDR had a lower reoperation rate for adjacent level when analyzed utilizing this fixed effect statistical model, but not according to the random effects model. Next. And we have 10-year follow-up now from the Bryan, the Prestige, the Mobi-C. And overall, the Bryan showed that the success rate at 10 years was 81 versus 64%. The adjacent level reoperation rate, although was not statistically significant, was 9.7 versus 15.8, and the range of motion was maintained. And this is a disc that's now been taken off the market, but still has withstood the test of time. Next. And in the Prestige LP, which is a currently used disc, as well as the Mobi-C, both found significant improvement in early pre-op maintained through 10 years and lower reoperation rates compared to their fusion cohorts. Next. Next. And when looking at real-world data, that is non-randomized observational studies compared with the RCTs, in this study, they found that there's no difference in the treatment effects between observational, in other words, what people are publishing outside of the IDEs, and the RCTs. So the data remains pretty firm. In addition, we want to maintain motion, and as Dom alluded to, of course I'm going to show this. So let's see the next slide. And if we see tabulated here all the different artificial discs, and not all the data is available for everyone, but we see that basically the data, the range of motion is maintained at least out to the 7-year follow-up, and we have a couple out to the 10-year. Next. And what about adjacent segment degeneration? You know, it's the old story. Is it, you know, just natural history, or is it increased stress based on what we're doing to that level? And, you know, the holy grail is that the artificial disc should produce less stress and strain, and biomechanically this has been shown. Literature generally supports it, but not all studies do. Next. So in this study, this was a meta-analysis. They looked at 20 studies, over 3,800 patients. 2,000 were fusion and 1,500 were ACDF. And they concluded that there's a lower probability of ASD reoperations with TDR after 60-month follow-up compared to the fusion. Next. This is a study where Dom was the lead author on, and this showed that at 2 years with our metal-metal Kineflex disc, it actually had very good data, except for the problem with metal-metal problem, showed that there's a greater percentage of patients that had degeneration, as circled by the little red circle, at 2 years compared to the TDRs, which maintained the same levels as pre-op and post-op. Next. And this comes from the MOBI-C data. It shows adjacent level surgery rates through 60 months. We see that the 1 and 2 level MOBI-C on the left were relatively small at 2 and 3+% compared to 11.4% for the fusion patients. Next. Now, this is a published paper from a group that had participated in a number of IDE studies, and they looked at their patients, and what they found was that for single level patients, the adjacent segment reoperation was 4.3% versus those of fusion, 15%, and the 2 levels 5 versus 12. Next. And in this study, again, it was a meta-analysis, and they found that TDR had significantly lower secondary surgery rates of 5.8 versus greater than 11% for the fusion patient. That is impressive currently. Next. And also, SPIVAC had published a paper looking at the adjacent level disease or radiographic changes based on the range of motion. And this included both fusion and TDR patients. Obviously, fusion patients are going to be grouped with the 0 to 3 degree. And as we see greater range of motion, we see less chance of adjacent segment radiographic changes when it's greater than 7 degrees of motion. Next. It's a little fuzzy because it also includes some of the adjacent levels, but reoperations, obviously, Dom said, if you have to salvage an artificial disc, you got to do another operation, do a fusion. So let's look at some of the data there. Next. So this was a study based on 6 prospective randomized IDE trials that we published, and we looked at our 84 disc replacements and 52 ACDF patients with a mean follow-up of about 4.5 years. Next. And our reoperation rate was about 8.2 for the TDRs and 21% for the ACDF, which was significant to P less than 0.05. Next. And other studies report a similar low reoperation rate with TDR compared to ACDF, but none ever showed a higher rate of reoperation compared to the TDRs. Next. And this is subsequent surgery rates coming from the MOBI-C data. And what they showed was 3 and 4% for the MOBI-C, and for the ACDF, it was upwards of 11 to 16% for the 2-level fusions, that is. Next. So a potential shortcoming Dom mentioned was heterotopic ossification, and as he said, what happens is the patient, in some cases, may turn into a fusion, but not all cases. So let's look at the data. Next. So the reports vary according to different studies, anywhere from 16 to 85%. There's several factors, and we're not sure really what caused it. Is it the operative technique? I used to think it was from the milling, but we see it with all different designs. And is it the patient characteristics? We don't know, but now we put the patients on a 2-week course of anti-inflammatories after surgery. This is purely anecdotal. We'll have data hopefully in the next year or two when we look at our data. Next. So in this study, they looked at 38 cases, and they looked at the amount of HO after these various timeframes. So let's show the next slide. And they didn't grade it other than moderate and or up to the severe level. And we see that at all time frames, we see increasing rates. So, although they didn't grade it according to the typical grades of grade 1, 2, 3, and 4, 4 is a complete fusion, 3 looks like it bridges, but there's still motion. Grade 1 is a little bit of bone, and grade 2, they still have normal motion. So obviously out to greater than 7 years, you're going to see a high amount of HO. Next. And this was the Bryan study with a follow-up of 94 months. Next. And HO was 50%. But again, they concluded that it didn't affect any negative outcomes, and there's still significant improvement even with the patients with and without HO. And they felt the patient that had more preoperative spondylosis had higher rates, and also with adjacent segment degeneration. Next. So in this sort of concluding data, it showed that basically the reoperation rate of TDR was superior to ACDF. Regarding radiographic outcomes, no firm conclusion could be drawn from the TDR infusion. TDR did decrease the rates of adjacent segment radiographic changes as well as disease compared to ACDF. Multi-level TDR may be effective and a safe alternative to ACDF. And the one-level TDR offers similar outcomes with the low reoperation rate and also versus the cost of ACDF. And although the data regarding the two-level is less robust, they may be as effective as the one-level TDR data. Next. So we're now seeing that level 1 data with 10-year follow-up from multiple prospective studies. And we've never seen anything like this for fusions, for cages, for plates, that we have even for the various graft materials. And the successful results early are being maintained out to 10 years. Next. So we're not seeing as a significant of the TDR failures, although Dom did show us one. There's no reported publication showing that TDR produces inferior results to ACDF based on the clinical outcomes or reops. And the TDR, unfortunately, may be close to the new gold standard for the typical cervical radiculopathy without all the other contraindications. Next. So like this like my 36-year-old patient that we did a TDR, had exactly the same picture, and especially for my 46-year-old patient that had a previous fusion, the TDR was an excellent option for them. So basically for this patient, even though next, he was work comp. In Texas, we don't get paid a lot of money for work comp, so therefore we can be very, very selective and have them go through psychological screening and pick our patients very well. I think that TDR is one of the newer implants, not one of the older implants, is an ideal solution. But as stated before, all the options are good for this patient. I don't think that any of them are a bad option. Next. Thank you.
Well, that was quite an interesting discussion. Now, as I mentioned before we started this, people voted based upon just the imaging, what they would do in terms of posterior cervical foraminotomy, ACDF versus arthroplasty. And I'd ask the audience to just type in to the comments section now after listening what they would do. But since we went through this case, I'd like to hear from each of you, if this were your patient, what would you do? And maybe we could start. Sig, are you still there? I think we may have lost
Paul. Paul, I'm here. Terrific set of presentations there. And in terms of just going roundtable for a vote, I think in somebody who's presenting as this patient does, with radicular pain, a degree of weakness, and a foraminal stenosis, I think a posterior cervical foraminotomy is a nice motion preserving option that doesn't burn a bridge. I think I would start with that, with the expectation that would get a good result.
Dom, we already know what you're going to say.
Well, if it wasn't comp, I'll tell you, if based on the patient's age, if it wasn't a comp patient, that ACDF would be my last choice. But if in a comp patient with, where you're looking for a more definitive procedure, I would go with ACDF first. I think that you picked a case with great equipoise, because I do think that every one of these would do well. But if it was just kind of a young, active, healthy person, I would either do a arthroplasty or a cervical foraminotomy. Debate aside.
Dr. Hartle? You're not coming through. Your audio is off, Dr. Hartle.
You're
Yeah,
muted, Roger.
yeah. So this is a great case. I agree. It could go either way. The one thing I can tell you is that, if the patient, a lot of patients shop around, they see 3, 4, 5 different surgeons. And especially in this case, if you're the surgeon who can offer a cervical foraminotomy, most patients will gravitate towards that option, because nobody really, I haven't met a patient yet who really likes having implants inserted into their spine. Obviously, it has to be a reasonable option. And I totally agree with Dom and with Richard that we have to make sure that residents, fellows don't lose the ability to do this operation. As exciting as the technology is, and Richard's data it's really striking. I mean, all the research that has gone into that, the technological refinements over the years, if you watch that over the last 15 years, it's amazing. But we got to make sure we maintain our ability to operate the spectrum, meaning do decompression, disc arthroplasty, fusion as indicated.
All right.
Yeah, Dr.
My turn?
Dyer.
Well, I've actually side more with Dom, but if he was a reasonable patient and he loved his job, he was going to go back to his job because he had neck pain and the arm pain, I would offer him the arthroplasty. Now, we have all of our patients see the psychologist. We don't want any baggage, don't want them on narcotics or anything like that. If he had any of those things, I would do the ACDF for the reason that Dom said, is that you don't want to give him a reason to have further complaints. And, although the foraminotomy, if he wasn't work comp, I would have no problem telling a patient, look, we can get rid of your arm pain and you'll do great, and it will work your rehab, and you can, hopefully get rid of your neck pain. So as Dom said, is one of those that it can go any of 3 directions. But, I would lean more towards arthroplasty if he's a reasonable candidate and I felt good about him and wanting to get better and go back to work. Unfortunately, work comp has a lot of negative, and we don't see so much anymore because they changed the work comp laws. And so the people that we do see are really pretty reasonable people that want to get back to work.
So, Dom and Rick, both of you discussed really patient assessment, patient motivation. And is there a screening tool? Is there some type of a questionnaire? Or what are you really looking for there to try and quantify that? Because in so many cases, it's a bit of a gestalt. But do you have some type of a screening tool other than using the psychologist that you might be able to assess motivation, might be able to assess somebody's stick-to-itiveness or their grit?
Well, we do have a psychologist. Andy Block has perfected what we call pre-surgical screening. And he has a series of tests that they go through, and he will rate them either as a poor candidate or a poor candidate and don't operate, or an okay candidate but needs to see me a little bit longer, or perhaps needs to be put on antidepressants. And that's not this case where it's only a couple months. But we do that. The Gestalt I use, and everybody has their own way. You sort of get a feel for the patient. If they come with their family members, you see a nice relationship. If they've been working, if they've not been taking narcotics, if they love their job, those are key things to me. And in fact, years ago, we published a paper on the 10 best and the 10 worst lumbar artificial disc patients and try to determine characteristics. We looked at x-rays. We looked at how that was positioned. We looked at all sorts of things, the positioning. For example, sometimes we would put them in and we go, oh my God, that looks terrible. It had no relation. The only thing that made a difference was whether or not the patient was working 13 weeks prior to surgery. It wasn't a great study, but it was interesting. We took our 10 best and our 10 worst, and that's the only thing that made a difference. So I think that tells you a lot about the patient's motivation and what they enjoy.
Rick, you're directing a spinal arthroplasty center there, and so I'm imagining a good number of your patients are coming with the expectation of getting an arthroplasty. When do you say no to arthroplasty? When do you say, no, this just wouldn't be a good option for you?
Well, Dom sort of alluded to a little bit. For example, if they have facet arthritis, there is no way you're going to put an artificial disc in them. And if they have no preoperative range of motion, there's no way. Although I must admit that, some of my colleagues that, do a lot of cervical arthroplasty, they're starting to do more and more spondylitic patients. And just like in lumbar arthroplasty, we will do patients that almost have bone on bone, and you can still get motion back with them, but it requires getting a CT scan to assess those facet joints. The other thing that Dom talked about is they have significant cervical kyphosis. No, an arthroplasty is not going to correct them. That's somebody you ought to do a fusion on. And he also mentioned about bone density. You routinely would screen all our lumbar and cervical patients, and we found that less than 3% of our cervical patients did we kick out because of osteopenia. Because unlike the lumbar spine where you need normal bone density, all the cervical arthroplasty studies basically said that they couldn't have osteoporosis. Now, some were different. Osteoporosis is a T-score that compares them to a 25-year-old that should be less than minus 2.5. Some of the studies were minus 1.5, some were minus 2.0. But even the ones that went up to, the osteopenia level didn't really have a significant amount of collapse or subsidence. So we look for the reason not to do them. And of course, if they have autoimmune disease and if they're on steroids and various immunosuppressive, you don't want to be doing them.
Rick, what is your cutoff for T-score for arthroplasty?
Well, lumbar arthroplasty in the lumbar spine is minus 1.0. And in the cervical, we stop doing them unless they had a history of a fracture. Then we'll go and do a bone density. But if they have had a fracture, they probably have osteoporosis. So, we recently changed that, Dom, and it was only after we looked at all our patients and we presented that actually, and it's going to be published soon. So we're much more liberal in the cervical spine because remember, a lot of these patients, even if they're older, they'll have some sclerotic end plates, and as long as you don't violate them, they'll be okay.
Excellent. So before they started, 50% of respondents said that they would do an ACDF, 25% said they would do posterior cervical, and 25% said cervical arthroplasty. When I was looking at this case, the guy is an incredibly motivated, just loved his job, is a hard worker, really wanted to get better. There were none of the red flags. He wasn't a drug seeker. And keeping in mind when I looked at this case, I took into consideration that he was in pain and spasm when this was taken and lying down. So you do get a little bit of the reversal of the normal lordosis when you're in spasm and lying down. There was some disc degeneration at C3-4, some disc degeneration at C4-5, elevation of the posterior longitudinal ligament, and I felt that taking care of the disc at C5-6, I felt, in my opinion, the best option for him was this. So I performed a cervical arthroplasty utilizing the MobiC. I've seen him in follow-up. He has had complete resolution of his radicular symptoms, complete resolution of his neck pain. He would have gone back to work if his job hadn't been postponed due to COVID. So he's actually done quite well. He's 2 months out, and this is what I chose to do.
And it looks great.
Thank you.
No argument.
So
Great job, Paul.
thanks. We do have a couple of people saying they would do an ACDF, and of course Dr. Gardaki is weighing in. He said he would do posterior cervical endoscopic foraminotomy, and if you ever get a chance to watch some of his videos, he does an absolutely amazing job with the endoscope. So it's certainly another option.
Yeah, I got to say, just looking at we didn't have the sagittal MRI scan to really be prepared before, but he's got underlying cervical stenosis and adjacent level disease. I mean, I think is a great candidate for posterior cervical. I would have done what I was assigned to talk about, which is a posterior cervical foraminotomy.
And Paul, because he did have some change to the levels above, that's even more reason, even though Dom doesn't think you get adjacent segment disease with fusions, or it doesn't make any difference. But that's why I would have done an arthroplasty if we'd seen all the pictures.
And actually, I used to do a fair number of posterior cervical foraminotomies. I was actually heavily influenced by Dr. Korik's group. One of my chief resident, Dr. Mike Cowan, was one of Dom's partners. And I was heavily influenced by actually your group, Dom. And I did a fair number of them, and I had a lot of success and I had a lot of failures. And I sort of got away from it. I still do it on occasion when I think it's a better option for a patient. But I have to say, in my patient population, my go-to operation is an ACDF. And when I get a young person with a normal-looking spine, a more normal-looking spine, in a single-level disease, I'll try for an arthroplasty, and that's my sort of the way I think of things.
Yeah, I would chime in with and back up Roger on the cervical foraminotomy as well. I think that is becoming a lost art, and it's sad. And that's kind of goes out to the residency directors and folks in residency. You need to get a training because it is a technically more demanding procedure. But once you kind of get down the logistics of it, in our case, sitting cervical. Roger's case, prone with pins and then with the tube. It really is a very slick operation. Again, motion preserving, minimally invasive, no implants. I do think that the indications are narrow as to the three that we've talked about, but actually this patient actually fits it pretty well.
So interestingly, now the results are in. The respondents, 57% said they would do a posterior cervical, 28% said they would do artificial disc, and 14% said they would do an ACDF.
Oh, Dom, I'm so sorry to hear that.
All right, guys. The Sharks.
Strong work, Roger.
There you go.
It's that.
So, I think there you go. I mean, what's old is new again. And I think that with some of the endoscopic techniques, with direct visualization, I think there's a bright future for cervical foraminotomy. So,
no question.
All right. Well, this has been a really wonderful discussion, and as always, I always learn a lot from listening to experts talk, and something I don't get a lot of chance to do. So I thank all of you for participating and sharing your knowledge with everybody.
Well, thank you, Paul.
Thanks, Paul.
And everybody stay safe, please.
All right. Well,
Take care, everybody. Thanks a bunch. Thanks.
Thanks, Paul. Thanks, everyone. Appreciate it. And have a good 4th. Be safe. Don't be around big crowds. Any crowd.
There you go. Take care.